So our next talk's on mesothelioma and lung cancer, and we've got Dr. Ross Mahia, who's a cardiothoracic surgeon and working at the Newcastle Private Hospital Medical Suites, and it's also at John Hunter Hospital, and he's got an interest in minimally invasive cardiothoracic surgery. So thanks, Ross.
Okay, thanks very much, and thanks for the invitation to talk. Been asked to talk about updates in malignant mesothelioma and lung cancer. Obviously, two diseases that have been around for a while. There have been some updates, and I guess the talk's more about what we expect in the future and how, as a community, we can treat these patients better or how we can improve their outcomes. So firstly, mesothelioma. It's obviously due to asbestos. We'll talk a little bit about epidemiology and what it is and the best treatment. So asbestos comes from the Greek inextinguishable or unquenchable, and it's really a group of minerals that form fibres, and it's this property that they can weave it into fibres that makes it quite versatile in terms of cladding and use in buildings. There's two types of fibres. There are the straight, stiff, brittle fibres, which are the amphibole fibres, and these are the more problematic ones and correlates with the malignant mesothelioma. Because they're stiff and brittle and often smaller, they kind of align themselves with the aerodynamics and end up in the pleura. The other fibres are serpentine fibres, which are larger, curly, twisted, and they tend to be caught in the proximal bronchial tree, and the ciliary mechanisms are able to get rid of them without too many problems. The good thing is that the serpentine fibres are the ones that are used more in industry. A great majority of them are used. However, the more problematic ones are, even though they're not used very much, has caused a lot of problems. So 93% of the serpentine ones are used in commerce, and only 7% in the straight brittle ones. So during the 20th century, it was part of the industrialisation process, and a lot of it was mined between the 19,000 and 2003, and global production peaked at 1975. And as you can see in the USA, where the peak of the mining occurred in around 1975, and after about 25-30 years, we have the highest incidence of mesothelioma, and that's also seen in Australia. It's quite common, and one of the things in diagnosing malignant mesothelioma is that there is a latent period where your exposure to asbestos had to be in the past 20, 30, 40 years beforehand to be able to get that diagnosis. So they're the uses, and as I said, it's this resistance to fire and heat, and also being able to be woven into kind of textile materials and cloths that made it such a useful material to be in industry. Now, was there a safe level of exposure? At one stage, they were talking about 5 fibres per mil in 1971, and then it's now reduced to 2, and then further reduced tenfold to 0.5, and now it's 0.1. And even then, we're still seeing patients now that even though being exposed 1.1 fibre per mil are still getting malignant mesothelioma. And the to keep that in mind, the people who the baggers in Winton, which is the mining company in Western Australia, their exposure was 600 fibres per mil, and of those 2,000 died of asbestos. Keeping in mind that they only employed 7,000 people in the mines, and only half of them stayed more than 3 months. So, quite. That's why the CSR and I think it's the Australian Blue Sky Company have had to pay a lot of money in legal costs, but quite a large amount of fibres exposure. And if you talk to some of the patients that come through with malignant mesothelioma, most of them have played as kids in like mounds of asbestos, thinking it's snow, and they throw it at each other, and they're just rolling in it, and obviously not knowing any better. So with asbestos, it's more than mesothelioma. You can have pleural effusions, local plaques, interstitial fibrosis, which is asbestosis in itself, also linked to lung carcinoma and other carcinomas in the oropharynx, kidneys, and GIT tract. Excuse me. Most of the problems is inhalation of the fibres, and as I said, it's the straight brittle fibres that become problematic, and they line themselves parallel to the airways and end up in the pleura. And what happens is that the macrophages attempt to ingest it and break it down, but they aren't able to, and then they release some chemotactic factors, which then causes mediator release, and you get reactive free radicals, and this is what causes this is what is thought to cause the carcinoma. And the tobacco smoke also is additive to this, in that it's got its own carcinogens, as well as impairing the mucociliary clearance of these fibres. So mesothelioma, it's an insidious neoplasm with no standard treatment and usually a dismal prognosis. So in Australia, there have been around 7,000 cases, and at the moment we are at the peak, and it's starting to plateau, and hopefully we're on the way down. In the United States, I think they're on their way down because they tended to stop their mining earlier, whilst the rest of the world seems to be on their way up. In the UK, there's greater than 1,800 deaths per year, and it's rising, and we think it's going to peak in the next few years. Not really sure how it's going to affect third world nations, but I think it's going to be quite a huge epidemic in that area. And this is in Australia. You can see that there is a steady incline of mainly affecting males, but also females, up to 2009. And we're hoping that we're now at its peak and on its way down. The males predominate 8-to-1, and usually in their 50s and between 50 and 70, usually present with non-pleuritic chest pain, shortness of breath, and a majority of them present with a pleural effusion. There are no useful tumour markers that we can use to diagnose this. So what usually happens is there's a pleural effusion with a normal pleura on chest X-ray, or there's some subtle pleural thickening, and then these kind of subtle pleural changes then become bigger, and you get multiloculated pleural effusions. And then it's usually a localized problem where they get a thick pleural rind and then obliteration of the pleural space. And then lastly, they get a lymphadenopathy, but they also get a direct spread to the chest wall, as well as diaphragm and then into the peritoneum. Often it's only to one side, and I think the reason for this is that because the prognosis is so short, they don't really get a chance to develop any symptoms on the other side. So this is what it looks like. This is quite advanced disease. You get a little. They can either be a localized collection, pleural based, obviously, with some rib spreading, and this is a more generalized form where it affects the whole parietal pleura and kind of encasing the lung. And so you get loss of lung expansion, as well as obliteration of the space. So that's what causes the shortness of breath. So the establishing the diagnosis. So cytology is only diagnostic in 25 to 33%. That's when you aspirate the pleural fluid and send off that fluid off for cytology, and that will only yield 25 to 33%. A closed needle pleural biopsy, where entering the chest wall and trying to biopsy the pleura as a blind procedure is a little better, but the best way to diagnose this is through a VATS biopsy. And what we look for is some fleshy looking appearance on the pleura, and we have to get deep biopsies to show that the mesothelioma is invading the fatty tissue, and then that becomes pathognomonic, and it's important for the patient because the diagnosis and the prognosis is so poor, it's easier to prove to the company that they have mesothelioma if they have pathology that supports their claims. So it makes it easier for them and less traumatic. And there are different subtypes. Excuse me. Thanks. The epithelial type, which makes up a bulk of them, have a better prognosis. The sarcomatoid and the mixed basic biphasic are worse. From a laboratory point of view, the diagnosis can be very difficult, and one of the even under the microscope, the epithelial subtype can be misdiagnosed from metastatic adenocarcinoma, sarcomatoid versus sarcoma, and the mixed cellular versus synovial sarcoma. So, I mean, they're all quite rare, but if they have a history of asbestos exposure and this is what it looks like, then they do get the diagnosis of malignant mesothelioma. Then after the diagnosis comes the staging, and most of this is done with chest CT, and we look at invasion of the chest wall and mediastinal structures, and having a look at the enlarged lymph nodes. This is mainly a localized disease, so it will invade local structures rather than going into the spreading into the lymph nodes and distal organs. MRI is useful in patients who have potentially resectable disease, but usually the CT is enough to be able to make that decision. Other diagnostic tools we use are thoracoscopy, mediastinoscopy, and PET. PET's quite good in terms of telling us whether it's localized disease and being able to determine whether they can go on to trimodal therapy. And so for trimodal therapy, the patient gets staged, and usually it's if they're in stage 1, then and it's localized to the pleura to one side, then there can be a case of going for resection. There are the staging, I guess there's 3 different systems that can be used. Some are quite complicated, such as the T&M, very similar to what's used in lung cancers. But unless you're actually treating them, it kind of and using them every day kind of becomes a little bit too difficult. And but it does help us stage the patient and see which ones we can help and which ones we can't. As I said, local invasion is the main feature, and if we can get them early enough, then the hope is that if we can resect the whole mesothelioma, and then we can stop it and give them a long-term survival. So the poor prognostic factors are obviously greater than stage 1. Things like thrombocytosis, leukocytosis, anemia, fevers, also the type, the histological type, the sarcomatous or mixed histology is worse. Older age group and poor performance status also have poor prognostic factors. And the median survival is 6 to 18 months, and that's with treatment. These aren't significantly affected by current treatments. What usually happens is that while they're on treatment, there is an arrest of the disease, but as soon as they've finished the treatment, the disease just keeps progressing as if nothing's happened. So it doesn't actually regress; it just keeps things at bay, and it's the local invasion that causes the main problem. So the role of surgery is firstly diagnostic, so we do a VATS, give them a diagnosis. Palliation, sometimes people will take out the bulk of the disease to try, in an attempt to try and arrest the tumour load to the patient, and rarely do we have a curative intention for surgery. But there are some patients, and these patients are usually the ones that have localised disease with no metastatic spread, and but usually they're patients who the mesothelioma has been an incidental finding, rather than someone who's come in with shortness of breath and a pleural effusion.
What is VATS?
Oh, VATS. Sorry, a VATS is a video-assisted thoracoscopy. So it's a minimally invasive approach, 1 centimetre incision that we can use a telescope to have a look around the whole chest wall, and then through the same hole we can do a biopsy and get a diagnosis. And usually we do this, the VATS, in the line of a thoracotomy, so that when the time comes we can actually excise that port, because there is a chance that you can get seeding into that incision at the time of trying to diagnose their mesothelioma. So the palliative options are a talc pleurodesis, and this is where there's an attempt to obliterate that pleural space so that the pleural effusions won't reaccumulate and cause them shortness of breath. So radical surgery with curative intent, it's quite a debilitating surgery, and what it involves is complete resection of all the gross tumour that's inside the chest. And what usually happens is we resect the whole pleura as well as the lung inside that chest. The diaphragm also goes, as well as the pericardium, and then that has to be reconstructed at the end of the procedure. So quite a long procedure, and not very well tolerated, especially in the elderly, and so it's not a procedure that's often done. I think in the region we've only done maybe 2 or 3, kind of in the last 3 or 4 years. There's a group in Western Australia. Obviously, they see a lot more of this, and also at RPA that do it more frequently, and their results are very good. And it has to be a trimodal therapy, so surgery in itself doesn't really significantly change the survival, but with the use of radiotherapy and chemotherapy, there are occasionally long-term survivors, and surgery's aim is to completely take out the gross specimens and decrease the tumour load on the patient, and then the radiotherapy and chemotherapy to try and mop up the rest. So this is a systematic review by Chris Cow and Tristan Yan, a group in RPA, looking at trimodal therapy for malignant pleural mesothelioma, and outcomes. I think not a very big study, but overall the results suggested that trimodal therapy was acceptable perioperative outcomes with good long-term survival, but in a very selected few patients. Other therapies that have been tried and unsuccessful is radioactive colloid and brachytherapy. This is kind of brachytherapy, which is infused into the pleural space, and then other things such as immunotherapy, gene therapy, have not shown any benefit at all. So in conclusion, although it seems that it is a difficult problem, hopefully we're on the way down from the peak, and we'll see less and less of these patients. But at the moment, really the only curative treatment is trimodal therapy. Any questions on mesothelioma? Yes.
Can I ask you one question? Is synovial sarcoma caused by exposure to asbestosis?
Can you repeat the question?
So is synovial sarcoma related to asbestosis? No, it's separate. The mixed or the biphasic histological type sometimes does look like synovial carcinoma, and so there can be a confusion, I guess, with the histological type, but there's no relationship between the two.
And if you have localized synovial sarcoma, can that be surgically removed and cured?
Yes. Again, we would go down the pathway of trimodal therapy, but I guess the chance of getting localized disease is very small. Usually it's an incidental finding, but if we get those patients, then I think they should be treated quite aggressively, especially if they're young, because their only chance of getting a good outcome is with trimodal therapy.
Just one more question. If those people have synovial sarcoma and the PET test done and they say there's a localized recurrence after surgery, what did you do for them?
Sorry, if there's localized recurrence.
Yeah. So can they be treated surgically again? Or can they be ablated? The laser?
I guess it depends on what structures it has invaded. So if there is a recurrence, then and it's localized and it is resectable, then sure, we can try and resect it again. But I think the chances of that happening are usually quite low. Usually, if there is occurrence, then it's quite an aggressive recurrence, and tends to obliterate the space fairly quickly. Okay, all right. So just a quick update on lung cancers, because we're running a little bit out of time. Worldwide, there's about 1.8 million people with lung cancers and estimated 1.6 billion deaths. It's obviously a bronchogenic carcinoma. 85% is non-small cell, and it's associated with cigarette smoking. Approximately 90% of all lung cancers are associated with cigarette smoking, and a 40-pack-year history has a 20-time risk of developing lung cancers than non-smokers. So this is the most important thing to stop patients from smoking. Other causes are radiation therapy and pulmonary fibrosis and genetic factors. Those are the type of lung cancers, adenocarcinoma being the most common, squamous cell carcinoma also quite common. And so I guess one of the updates is since 2008 you have personalised genotype directed therapy. So we stain the tumour with EGFR, ALK and ROS1, and with these, if they're positive staining for these receptors, then we can give them a tyrosine kinase inhibitor, which improves their outcome and improves their response to chemotherapy. So it's quite important for us to do that for all the lung cancers that we get. And at this stage now, only since the beginning of the year, it's now automatic that we do these stains, and we can improve their outcomes. Clinical presentation, cough, hemoptysis, chest pain, and as most of you would know, 75% of patients who present with lung cancer have one or more symptoms, and a majority present with advanced disease. Other presentations are hoarseness, effusions, and superior vena cava syndrome. So the important things are to establish diagnosis, accurately stage them, and give them appropriate therapy. Unfortunately, there's no complete algorithm for all patients that present with lung cancer, and the most concerning thing is that 75% of patients have advanced disease that are incurable, really. Initial imaging is chest X-ray and CT scan, and then PET scan to help us stage the patient. Tissue diagnosis is most commonly used is EBUS, which is using endoscopic, either through the bronchus or through the esophagus, ultrasound. The ultrasound can localise where the tumour is, and a fine needle biopsy can be performed. Other uses are CT guided FNA, surgical biopsy, and sputum cytology. So for most patients, the treatment after initial evaluation, those in clinical stage 1-2 are decided upon whether they are a surgical candidate. And if they are, then they go through resection. If they're not, usually due to poor lung function or other comorbidities, they either have the SABR, which is kind of a directed radiotherapy, or definitive radiotherapy, and then surveillance. And those with either clinical stage 3 go to a multidisciplinary approach, and they either have have a trimodal therapy where they get radiotherapy, chemotherapy, get restaged, and if they if they get down to stage 1, 2, then they can come down this pathway again. I guess the most important thing at the moment is screening and using a low-dose CT scan. At the moment, this isn't recommended in Australia, but there's a group in Western Australia who is trying to discern whether this is a good thing or not. And the problem is that the low-dose CT scan, although the radiation from it isn't very high, it picks up a lot of things. And so even for the high-risk group, as you see there, the 55 to 80-year-olds with a large smoking history who are current smokers or have quit recently, they are a high risk, but they also have a high false positive rate. And it's not the actual low-dose CT scan that's the problem. The problem is the information you get from this investigation. What do you do with it? So a lot of people will get some sort of positive CT scan with a lesion, and then do they go down the pathway of having fine needle biopsy or surgical resection? It's very difficult to know, but it's something we need to do because as I said before, 75% of patients of all comers of lung cancers have advanced disease at time of presentation. And despite the advances in both surgery and chemotherapy, the 5-year survival is only 16% for all comers. And the low-dose CT scan has shown in the US that there's a 20% reduction in lung cancer mortality. So I think in the future, I'm thinking 2 or 3 years that we will be doing a lot more low-dose CT scans. But it's the algorithm after that once you've found a positive finding in it, that's what needs to be worked on, I guess, to try and discern which will give us the highest yield. Because if we can get these patients early on, get them in stage 1 and 2, then we can make an impact on that 16% 5-year survival. Thanks very much.
Especially thank Ross for suffering through the talk. He needs to go home to bed, I think. Can I ask a question?
If you've got just a localized cancer in one lobe of the lung, would the lumpectomy or the lobectomy cure the problem?
Repeat the question.
So localized cancer to the lobe, will lobectomy or pneumonectomy cure the patient? The short answer is yes. For stage 1 patients with a small localized cancer, a lobectomy or a pneumonectomy, depending on its position, we're looking at about 80% 10-year survival rate. So the follow-up would be chest x-ray every 3 to 4 months for the first 2 years, and then a yearly chest x-ray up to 10 years. Yes, 80% survival at 10 years.
I might let Ross off the hook. Thanks again.